وان شاء الله يحافظ على الوقت مشان لا ندور كثير بعدين.
Type 2 diabetes and cardiovascular disease. The prevalence of coronary heart disease accounts for about 14 to 21%. Heart failure about 18 to 20%. Cerebrovascular diseases about 10 to 29%. And stroke about 8 to 12%. Type 2, the prevalence of the risk factor. Type 2 diabetes per se is one of the major four independent risk factors for cardiovascular disease. This includes diabetes, hypertension, and dyslipidemia, and smoking. Although diabetes per se is associated with other cardiovascular disease, the first is what's called glycemic variability. The second is the hypoglycemic complication. The third is the presence or absence of hypertension, insulin resistance, obesity, dyslipidemia, and endothelial dysfunction and inflammation. What's the pathogenesis of cardiovascular disease in type 2 diabetes? There is an increasing in the angiotensin II and increasing the transglycation in product in hyperglycemia, hyperlipidemia, and insulin resistance and lipotoxicity. This leads to changes in the cellular metabolism with mitochondrial dysfunction. Mitochondrial dysfunction leads to the cardiomyocytes and calcium dyshomeostasis. Also, there is a cardiomyocytes dip and cardiomyocytes hypertrophy leading to cardiac hypertrophy. Also, there is an increase in the oxidative stress with increasing risk of inflammation that leads to endothelial damage and mitochondrial dysfunction with myocardial ischemia and cardiac dysfunction, diastolic and systolic dysfunction. Atherosclerosis and cardiovascular and diabetes. Diabetes is associated with atherogenic dyslipidemia and dysglycemia and insulin resistance. All these cause a pro-inflammatory state with endothelial dysfunction and vascular inflammation that accelerate atherosclerosis. Diabetes per se can cause heart failure, and heart failure can cause diabetes. How heart failure can cause diabetes is, in heart failure there is a metabolic requirement is increased, and there is a pump failure. This causes hypoperfusion and venous congestion. Congestion in the liver and the pancreas will lead us to decrease of impaired glucose homeostasis with diabetes. Also, there is increased autonomic nervous system. There is adrenaline increased glyconeogenesis and glycolysis, so it causes diabetes. The drug used in the treatment of heart failure, like a beta blocker or diuretic, cause hypokalemia and sympathetic overactivation and insulin resistance for subsequent diabetes. So heart failure can cause diabetes and diabetes can cause heart failure. Type 2 diabetes and arrhythmias. In type 2 diabetes there is increasing risk of that, especially in the current hypoglycemia. There is increasing sympathoadrenal response with increasing adrenaline that enhance the risk of arrhythmia. Also, inflammation causes fibrosis and structural remodeling that results in arrhythmias. So, type 2 and hypertension, further in diabetes, there is insulin resistance enhanced sodium reabsorption by the kidney. Also, it causes endothelial dysfunction and inflammation with subsequent increase in the blood pressure. What's the risk factor or the factor that should be considered when you treat a type 2 diabetes at risk for cardiovascular diseases? The first is the treatment target. The second, you have to do a proper type glycemic control. The third, you have to avoid glycemic variability. You have to avoid hypoglycemic complication. You have to avoid weight gain. You have to treat diabetic dyslipidemia. You have to reverse endothelial dysfunction. And you have to use a drug that has a long-term cardiovascular beneficial effect, especially effective in reducing the major adverse cardiovascular events. You have to early introduce a new drug is called a disease diabetic modifying drugs. Disease diabetic modifying drugs. So the treatment target, as we say, you have to keep an A1C in or around your 6.5 to 7 or even below. The importance of the tight glycemic control, there was found that any increase in the hemoglobin A1C by 1% is associated with increase in the cardiovascular mortality by 11 to 16%. You have to treat all other cardiovascular risks in type 2 diabetes. You have to avoid hypoglycemia, because hypoglycemia will cause inflammation and increase it in the C-reactive protein. Hypoglycemia will increase adrenaline, that increase the risk of arrhythmia. Hypoglycemia also induce endothelial dysfunction. You have to use a drugs that affect in the both fasting and postprandial blood glucose and glycemic variability. What is the glycemic variability? It is a clinical term. Glycemic variability refers to the blood glucose oscillation that occurs throughout the day. This is called short term, including hypoglycemic period and postprandial glucose increase, as well as a blood glucose oscillation that occurs at the same time on the different day. This is called long-term glycemic variability. So, the risk of cardiovascular disease is not dependent on the HbA1c target. Some they say my target is normal, but still I have developed a cardiovascular disease. This is because of the most of the drug does not target the glycemic variability or does not inhibit the glycemic variability. What is the effect of glycemic variability? There is increased inflammatory markers and cytokinase leading to vascular inflammation. There is increased production of reactive oxygen species. There is increasing oxidative stress. There is impaired production of nitric oxide and vascular endothelial blood factor leads to vasoconstriction and impaired angiogenesis. There is increased platelet aggregation and aggregation. All these leads to endothelial dysfunction, thrombosis, and increased plate instability, and this leads to the macrovascular complication. You have to use a glucose-lowering drug that improves dyslipidemia and decrease the blood pressure. You have to use a glucose-lowering drug that overcomes endothelial dysfunction. What is the adverse effect of endothelial dysfunction? It will lead to vasoconstriction, thrombosis, and inflammation. You have to use a drug that decreases the body weight. The effect of the weight gain during treatment of type 2 diabetes will increase insulin resistance, will increase the blood pressure, will cause the diabetic dyslipidemia, and increase the risk of hyperglycemia, and increase the risk of inflammation, and endothelial dysfunction. They was found that a weight gain associated with 20% increase in overall mortality, a 2.25 kilogram increase is associated with 20% rise in the cardiovascular risk factor in men and 37% increase risk factor in women. Abdominal obesity increased the odds ratio for myocardial infarction to 2.4%. You have to use a drug that overcomes insulin resistance. Insulin resistance will accelerate atherosclerosis. Insulin resistance causes endothelial dysfunction. Insulin resistance causes dyslipidemia, and it increases body weight, and it induces coagulation and fibrinolytic defects, and increase the blood pressure, and increase the risk of inflammation. You have to use a glucose lowering that decrease inflammation and that decrease coagulopathy. Early use of diabetic disease modifying drug, irrespective of glycemic control. So any patient with newly diagnosed diabetes, type 2 diabetes, you have to start with metformin. So these are one of the disease diabetic modifying drugs. This including your sodium glucose transporter 2 inhibitor or glycogen lipotide 1 receptor agonist or dipeptidase. You have to use a glucose lowering drug that has a beneficial effect in reducing the major adverse cardiovascular event. Major adverse cardiovascular is defined as a record or diagnosis of either coronary artery disease, including MI or CABG or vertiginous intervention, stroke, and cerebral vascular disease. So this is the summary of the drugs which are the best now used. The three drugs which are sodium glucose linkage transporter 2, glycogen lipotide 1 receptor, dipeptidase. This is called a disease-modifying anti-diabetic drug. But nowadays they add a metformin, including to these three drugs. So they have a proper reduction in A1C, there is no risk of hypoglycemia, they decrease the body weight, particularly glycogen lipotide 1 has a marked effect in decreasing body weight. They decrease the low density lipoprotein and total cholesterol and triglycerides and increase the high density lipoprotein. They improve insulin resistances. They decrease the blood pressure. They have an improved effect on the endothelial dysfunction, and they decrease the pro-inflammatory cytokines, and also they have an effect on the coagulopathy by decreasing plasminogen activator inhibitor type 1. So, what happens in the patient, diabetic patient with heart diseases? The heart function is decreasing. These drugs will increase the heart function. The risk of arrhythmia is increasing. These drugs will decrease the risk of arrhythmia. Fibrosis is increasing. These drugs will decrease the risk of fibrosis. Glucose uptake is decreasing. These drugs will enhance the glucose uptake. Lipid accumulation is increasing. This drug will decrease the lipid accumulation. Inflammation is increasing. The drug will decrease the inflammation. Myocardial stiffness is increasing. This drug will decrease myocardial stiffness. The infarct size, this drug also decrease the infarct size. So what is the new guideline in alpha-montage? They say the first line drug in patient or drug native patient is the metformin. Do you have another drugs, your disease diabetic modifying drug, irrespective of glycemic control? In alpha-montage, no. In alpha-montage, the first drug is sodium glucose linked or glycogen like peptide. Do you add another drug irrespective of glycemic control? Yes. In 2020, the first drug is metformin. Do you add another drug irrespective of glycemic control? Yes. So this is a new guideline. You have to start with lifestyle, metformin, plus one of the disease-modifying drugs. This is the drug used in the treatment of patients with established or at risk for cardiovascular diseases. And as we said, in the drug-native patient, metformin is the first drug. You have to add another drug irrespective of HbA1c target. In the patients who are already using the drug, you have to add one of the diabetes disease modifying drugs. In heart failure also, if the patient is metformin, it's better to use sodium glucose linked transporter inhibitor, which has a beneficial effects in reducing the heart failure and risk of hospitalization in the patient with heart failure. And thank you for listening.